In PhysioEx number 4, I asked you to do activities 1, 2, and 4. Activity 1 took you the longest, but there's a lot of good stuff in there. And it was a perfect application of the game we played with the HPT pathway when we used our arrows for up or down for those 3 slides when we talked about over-secreting tumors or under-secreting tumors. If you turn to your data, please understand, in order to study well for your lab exam, I really urge you to reread the introduction. I also urge you to read the boxes, for example, on page 59, the equipment used. It tells you about the equipment and how it works. That's important that you know what you did and what it did for you, meaning the equipment. And then let's look at chart number 1. And I had that on video. That was awesome. I am recording this and I will upload it to YouTube so that you can review and listen to this as many times as you want. Please understand, when you see my data, it will be slightly different than yours. Slightly different numbers, but the trends should be the same. In fact, if you repeated the experiments, you'll get slightly different numbers. It tries to mix things up a little bit. We played with 3 different mice. One was normal, or rats, I should say. One had a thyroidectomy, which means its thyroid gland was removed. And one was hypophysectomized, which means its anterior pituitary was removed. In the first experiment, we took a baseline read of their metabolic rates. Do not worry, do not memorize how to calculate the metabolic rate with the equation that they gave you in the manual. From the baseline read, you should have gleaned the following. The normal rat had a higher metabolic rate than the other 2. The other 2 had hypothyroidism. They had a lower metabolic rate because either they were missing the thyroid gland itself, or the thyroid gland was not getting TSH because the pituitary gland was missing. Any questions on that one? Okay, so that's our baseline read. And in the review questions, they frequently asked you to compare the rats in the following experiments compared to their baseline or compared to the normal rat's baseline. In the next experiment, we injected thyroxine. We injected thyroxine into a normal rat. Well, this created the normal rat to have hyperthyroidism. You should have seen that the metabolic rate increased. The next rat, the thyroidectomized rat, by injecting thyroxine, this essentially was hormone replacement therapy. We kind of rescued the rat, right? Its metabolic rate improved. It improved even higher than the normal rat's baseline metabolic rate. In the back of this exercise, in the review sheets, one of the questions says, did we inject the right amount, too little, or too much? I don't ask you that. I'm going to ask, was there an improvement with the metabolic rate? Yes, there was an improvement. Those are the types of questions I'm going to ask you. Because if we wanted to answer that question really well, we should be doing statistical analysis on it. And we're not going to do a chi-squared test and find out if one was in the certain percentile of the other one. I don't care. Did it improve? Yes, it did. We also injected thyroxine into the hypophysectomized rat. You should have had a similar result to the thyroidectomized rat. Injecting thyroxine helped improve that rat's metabolic rate. In the next experiment, we injected TSH. Now let's review. How can a thyroid become enlarged? It's one of two ways. Okay. That's a result of that. What directly causes the thyroid gland to get bigger? Hyperplasia and hypertrophy. Do you remember? Okay, how do we get more activity of the thyroid? Keep going back. TSH and TSI. Those are the two mechanisms. If TSH goes up, or if we have Graves' disease where we have TSIs, the thyroid gland is overly stimulated. We were not playing with rats that had Graves' disease. So we're now going to inject TSH. The normal rat, when we injected TSH, its metabolic rate went up. Why? The thyroid gland was being stimulated more. Did we palpate a goiter? Yes, and I asked questions about which rats got goiters and why. Again, you get the goiter from overstimulation. How do we get overstimulation? More TSH. Why? Because we might be having negative feedback inhibition failure or TSIs. So the normal rat, its metabolic rate went up, it was hyperthyroid, and it had a goiter. In the next rat, the thyroidectomized rat, we did not palpate a goiter, did we? Why? What's the target for TSH? There's no target gland, of course not. So, and also TSH didn't help this rat. Its metabolic rate was not improved. Why? No target gland. Then we injected the TSH into the rat that had the pituitary removed. What happened? We replaced the missing signal, didn't we? Its thyroid was just fine. It just didn't have the signaling molecule. So when we injected TSH, that thyroid gland that was still there responded to it. We probably gave too much. Why do we know that? The goiter, right? It was probably a little bit too much. We overstimulated it. But the rat's metabolic rate did improve. Okay. Next and last one, propylthiouracil, PTU. PTU blocks the iodinase. That means you can't attach iodide. If you can't attach iodide to the tyrosine residues, can you make a working thyroid hormone? No. You're missing an ingredient. So when we injected PTU into the normal rat, think negative feedback mechanisms in that normal rat, thyroid hormone level went down in the normal rat. It became hypothyroid. But we detected a goiter. Why? Feedback. Mama hypothalamus. I'm not detecting thyroid hormone. So TRH would go up, TSH would, there's your goiter cause, right? Overly stimulating the thyroid gland, trying to rev it up, but we've blocked it. When we injected PTU into the thyroidectomized rat, well, that was a waste of time, wasn't it? Why? No thyroid. There's no target for the PTU. And then when we injected PTU into the hypophysectomized rat, did anything change in that rat? What happened to its metabolic rate? Was it the same as baseline, roughly? Yeah, because that thyroid gland wasn't getting the signal anyway. And PTU, well, the thyroid gland isn't getting the signal anyway. PTU is just like adding insult to injury, right? Didn't do anything. Did we detect a goiter? No. PTU doesn't give a goiter. TSH does, or TSIs. Are there any questions from that activity? Either the activity questions, the review sheet questions.
Number 10.
Number 10 in the review sheets? Is that it?
Activity.
activity question number 10.
It's kind of what you were just talking about.
Oh, so propylthiouracil inhibits the production of thyroxine by blocking the attachment of iodide to tyrosine. What naturally occurring problem in some parts of the world does this drug mimic? If I block the attachment of iodide, it's as if I don't have iodide. Remember the picture from my slide where I had the woman with Hashimoto's disease, then the baby with cretinism, and then the woman with the very large goiter. And she had that large goiter, if you remember I said, because she lives in a place where she doesn't have iodide. You block the iodide, it's as if you don't have it. And when people develop a goiter like that from iodide deficiency, this is called endemic goiter. If you ever read the words endemic goiter, number one, you know the person has hypothyroidism. Number two, you know it's because they don't have iodide in their diet. And number three, they have a goiter because the TSH levels are high in them from the lack of negative feedback inhibition. So endemic goiter tells you three things. That's a very good question, activity question number 10. Anyone else? No? Okay, then we'll move on to activity 2. The only reason why I assigned activity 2 is because you were using a spectrophotometer. And we've already done a lab with a spectrophotometer. We know about Lambert-Beer law. We know that absorbance and concentration are directly and linearly related. In activity 2, you had to first do a standard curve. Your standard curve should have come out directly and linearly related. It's only after you show that relationship can you then use the standard curve to calculate your unknown patient samples. If you look at chart 2.2, you see that we were assessing the values of plasma glucose levels after fasting in 5 different patients. Do not memorize the levels of FPG, fasting plasma glucose, and their ranges to determine if they were suggestive of diabetes, if they were impaired, or if there was no worry about them. But you should have realized that patients 3 and 5 had plasma glucose levels that were suggestive of diabetes, that patients 4 and 2 were impaired. What are we going to tell those 2 patients?
Watch your diet.
Watch your diet. We're going to want a follow-up too, right? In a few months or so, whatever the doctor wants, we're going to see if those levels are getting worse or if they improve. Is it a fluke? But we're going to want a follow-up. Now, I have to tell you that fasting plasma glucose levels these days, the normal range is different than what the PhysioEx told you. They actually will start flagging you if you hit 100 milligrams per deciliter. They want it lower than that for a fasting plasma glucose level. And the Monday, Wednesday class said, why would they lower it? Why would they do that? Why would they change normal values? And I said, actually, in medicine, this happens a lot. It's an effort to raise the bar, meaning raise our quality of health and what we think of health, make it more stringent, make us work harder to have a healthier body and a healthier life. So that's why by raising the bar, they lowered the glucose levels that you should have during fasting. They want us to eat healthier. They want us to be more active. They want us, in fact, blood pressure, normal, used to be 120/80. That used to be like, good job. You would get a gold star for that. Now that's pre-hypertensive and they start lecturing you about it. So again, they're trying to raise the bar. Number of drinks per week. I might as well move to Utah. At least I'll be in an environment where I can't buy it. Honestly, why would they do that? to keep us healthier, right? Both physically and mentally, not have substance abuse, not be reliant on it. They do this all the time to us. And is the irony lost on you? Is the irony lost on you? Go stand outside Mission Hospital. Look at the nurses and doctors that come outside for a break. Is the irony lost on you? My dad used to have this saying, do as I say, not as I do. That's why I have chosen a doctor who is like the epitome of health. He's my age. I look at him as a role model. I'm like, if you're doing it, gosh darn it, I need to too. And when I first started going to him, he said, why are you here? You're healthy. I said, because you made a good catch with me. He's the one that caught the sepsis and intervened, made a good call with me, allowed me to go home because I was like, I don't want to go in the hospital. He made me call my mom, and he talked to my mom. So my mom's a nurse. If she comes over and monitors me, can I go home to my blankie and my pillow and my fan? Because I need that. He's like, let me talk to your mom. But he's and when I came back to him, he's like, what are you doing here? I said, you are a good role model. You get on me about things. And he said, okay, so drug use? Well, no. But alcohol is considered a drug. He's like, let's talk about that. How much do you drink? And I was very honest with him. I was like, but I don't feel like I need it all the time, and I don't drink it all the time. And he's like, okay, I'm not worried about you. I said, really? Because that's above what they recommend for women per week. He goes, I'm not worried about you. It's the ones that aren't honest with me that I'm worried about. I said, you do understand that the formula is any number of drinks I admit to, you should multiply by 3. That is the rule in medicine. He goes, that's the rule, but I can tell you're being very honest. Otherwise, you wouldn't be here asking me to keep you healthy. We're like, yep, that's right. So that's part of the reason why they're constantly lowering, changing set points, alcohol use, blood pressure, fasting glucose levels. They're trying to get us to rise up and take more preemptive strikes to keep ourselves as healthy as possible. And then if we go over those things, that's an opportunity for the physician to talk to us. Say, you know, if you can't rein this in, I'm going to have to give you medication. And that's part of the reason why I went to Dr. Hart. I said, I got prescribed blood pressure medication by this other doctor. I want us to have a bet. Next time I see you, if I lose weight, my blood pressure is fine, can we start taking me to a half a pill, my blood pressure medication? And if I'm good for another year after that, can we take me off and see how I do? It's like, game on, let's do it. So I kind of like having a doctor like that. It's very inspirational. Are there any questions about the spectrophotometer? No, you're geniuses. Lambert Beerlop. Okay. I didn't have you do the hormone replacement therapy, and I'll tell you why, because I told the Monday, Wednesday class. Hormone replacement therapy, when it comes to estrogen hormone replacement therapy for women, for the sake of osteoporosis and that sort of thing, it hasn't come out to be what we thought it would be. In fact, now it's very situational. If a woman has history of certain types of breast cancer, the estrogen can feed some types of breast cancer. So it's not the gold star standard that it used to be in the 80s and 90s. We've kind of moved away from that and said, if we're worried about her for osteoporosis, why don't we try the bisphosphonates? Why don't we try vitamin D supplements and calcium supplements? Let's start there before we start mucking with estrogen. Too much estrogen can also lead to more blood clotting, and we don't want to form blood clots when we don't need them. Any of you who are on birth control pills, if you open your packet and take out that piece of paper that is folded, and when you unfold it, will occupy that entire wall over there. And if you read all of the possible side effects, one is if you're a smoker over age 40 and taking these estrogen pills, you're at a higher risk of blood clots. And you're at a higher risk because you're probably less active, sitting around more. The estrogen, that's the steroid, and then smoking also activates platelets, so that's why you're more at risk. All right, so now we moved on to activity 4. In activity 4, we were playing with the HPA pathway. Very similar game as the rat experiment that we did, but in this case we had patients. And we were measuring their ACTH levels and cortisol. Again, this is the same kind of game we played with our arrows in class. We did it with the HPT, but you heard me say we can play the same game with the HPA. We had to figure out if the person had Cushing's syndrome, which means it could be iatrogenic, physician-induced, where they're taking an exogenous cortisol. Cushing's disease was another one. In Cushing's disease, it is the pituitary that is over-secreting, so ACTH and cortisol would be high. We played with Addison's disease, which is primary hypoadrenalism. All 3 layers of the cortex are impaired, and it's the cortex fault. And then secondary adrenal insufficiency. This could be because the anterior pituitary is under-secreting, right? That's what we were told in the PhysioEx. So we assessed 5 different patients. In patient 1, it was secondary adrenal insufficiency. We saw the ACTH was low, and as a result, the cortisol was low. The cortex was not getting its signal. And which layer is the only one that directly obeys ACTH? Which layer obeys the HPA pathway? Jennifer is saying. Helper, zona fasciculata, good. Patient number 2 had Cushing's syndrome. Now we don't know if it's from an ectopic tumor or if it's iatrogenic, physician-induced, but we know it's Cushing's syndrome because ACTH was low and the cortisol was high. Patient 3 had Cushing's disease. The anterior pituitary was over-secreting. ACTH was high. As a result, the zona fasciculata over-secreted cortisol. Patient 4 had primary adrenal insufficiency. ACTH was high, and yet cortisol still wasn't being released. And then the last one, 5th, had Cushing's syndrome. High cortisol, but low ACTH. Again, we don't know if that was physician-induced or some sort of tumor on the adrenal cortex. Any questions? No? Okay. Well, Tuesday class, you have a